So, thank you all for joining us. We are Tell Every Amazing Lady About Ovarian Cancer, also known as T.E.A.L. We are based in Brooklyn. We are an ovarian cancer foundation with a community center in Brooklyn. Our mission is, there are 3 parts to our mission. Sorry guys, technical difficulties.
Hi guys, can you hear me now okay?
Yes, we can hear you. I started a little bit.
Yeah, thank you, Melissa. Sorry, I had some technical difficulties there, but I'm back. And as you heard, some of our mission, we're based in Brooklyn. We have 3 parts to our mission: to promote public awareness and education, to provide support to survivors, and we fund medical research. You'll find us all over New York City and beyond, promoting awareness and education with just about everything that we do, because there's no screening test for ovarian cancer. So here's some photos of us at some of those health fairs and hospitals and schools. A big part of what we do is really provide information to the public about this disease that has really limited information, even when it comes down to doctor's offices, really trying to get the word out. So even when you're sitting maybe in a waiting room, you might see one of our cards. So we also light up buildings and monuments all over the city, and our community center, which is based in Brooklyn, provides a lot of resources for not only the public but also for families. So every year at our T.E.A.L walk especially, we have a survivor program and survivor ceremony. That's one of the ways that we support survivors. And there's some pictures in here coming up of our program. That's a lot of our ovarian cancer survivors in New York City, all on stage in Brooklyn every year. It's a really beautiful moment not to be missed. And we consider a survivor anyone who's ever been diagnosed with ovarian cancer, whether it was 50 years ago or yesterday, whether they're in remission or they were currently being treated. So if you know any survivors, please let them know about us, because we have a lot of free programs and resources, not only for them, but for their families as well. We also fund medical research at some of the country's most prestigious hospitals and institutions. The donations that we receive each year, a portion of that does go to medical research, which is so necessary because there's no accurate screening test for ovarian cancer, and we're always trying to prolong the life of an ovarian cancer survivor so that they have better treatment. So check out our website for more of the research that we do. And most important thing that you might learn about tonight, besides learning more about genetics, is that there's no accurate screening test for ovarian cancer. Some of you guys might know that already, but there's also symptoms and risk factors, and we're definitely going to cover some risk factors tonight. There's also usually a late diagnosis because it's such a tough disease to catch early. And one of our messages is always to listen to your body, understand those symptoms. You can go to our website to learn more about them, but there are things like frequent back pain and frequent urination, bloating, and abdominal pain, pelvic pain. And those are always when you are experiencing them for more than 2 weeks and they're not normal for you. So we encourage you to keep all your doctor's appointments and make sure that you go for your annual screenings. Even though there's no ovarian cancer screening, we don't want you to forget about your mammograms and your colonoscopies and everything else that might reduce your cancer risk to be caught early. So it looks like we're ready to begin to switch over to Flora. So I wanted to first tell you guys a little bit about one of our board members. Her name is Flora Poleshchuk. She's been kind enough for us to moderate for this evening and volunteer her time. So Flora Poleshchuk is a certified genetic counselor specializing in hereditary cancer genetic counseling. Flora used to work with patients at Maimonides Medical Center in Brooklyn, and her current role right now is with Myriad Genetics, providing clinical support to preventative care clinicians in the New York City area. Flora, we'd like to thank you for moderating for us tonight, and we're now going to turn it over to her. And everyone watching right now, your screen will switch in a moment, and it will begin to show Flora's slideshow. So Flora, can you hear us?
Yes.
Great. Okay, so just a moment, we're switching to her screen. And now I believe, there we go. Great, so Flora, take it away.
Thank you so much for having me present this evening. So the topic of my presentation is managing familial and hereditary cancer risks. And first off, I would like to just mention that I am a certified genetic counselor, and I am employed by Myriad Genetics Laboratories. And many of the slides you will see this evening are Myriad slides. So our agenda for this evening is, why is cancer family history important? We will dive into that, and we will, as part of that, review some common hereditary cancer syndromes, including BRCA1 and 2, which are associated with hereditary breast and ovarian cancer syndrome, and the most common cause of hereditary colon cancer and endometrial cancer, which is Lynch syndrome, and then some other hereditary cancer risk factors that are important to know about when we evaluate a family history. And probably most importantly, we will talk about management strategies for individuals with these hereditary risk factors. At the very end, we will hopefully have time to answer a few of your questions. So when we think about cancer, it's easy to kind of think about it as a pie graph. And if we were to divide that pie graph into subgroups, we would see that the majority of cancer actually happens by chance. In other words, it's sporadic. Sporadic is just another word for we don't really know what's causing it yet, but we do know that there will be many people out there that have maybe one individual with cancer in the family. It doesn't look like it's forming a pattern. But then, as you could see in light blue, teal color, there's some people that have what we call familial predisposition. So it's about 15 to 25% of people have more than just one person in the family with cancer. So there might be something a little more suspicious, but perhaps not quite forming that picture of a hereditary pattern. So hereditary means it's something that's getting passed on. There's typically a specific single gene factor, a single gene either from the mom's or dad's side that's getting passed on that makes a person at higher risk. So that hereditary group in dark blue is at higher risk for cancer than the familial group, or even and especially the sporadic group. So let's talk a little bit more about this hereditary group, because the beauty is, and that's why evaluating family history is so important, if we could assess accurately whether there's a hereditary component in a person and their family, there's so much more we could do for them in terms of medical management, and certainly as part of T.E.A.L's mission, making people aware of especially ovarian cancer risks. So what are the flags? We call them flags for genetic assessment. So these are the three flags. One is cancer at an early age, two is certain rare cancers, and three is multiple cancers in a person or in a family. Let's go to number one. What would we consider an early age of onset? Obviously, people are living longer, people are aging, but certainly early means anything under 50. So especially breast cancer, 40 to 50, especially younger cancers, under 40 especially is very young. So rare cancers, number two, are male breast cancer. Men, you don't really think of men as having breast cancer, but a man with breast cancer is suspicious. There could be triple negative breast cancers. Those are suspicious. Or sarcomas or other unusual, more rare cancers should be flags for a further assessment in the family. Multiple cancers. Multiple means more than 2 or 3 cancers running on the same side of a family. So when we talk about hereditary risk, we're talking about something that's either maternal or paternal. So multiple cancers, for example, sister, mom, grandma on the same side, or 2 aunts and a grandma, or a grandfather, a brother, and an uncle. Or it could be either gender. It could be 2 aunts and a brother. Those are the patterns that we look for. So let's dive in a little deeper. BRCA1 and 2 are, again, hereditary breast and ovarian cancer syndrome, and these are the 2 genes that are most commonly associated with a hereditary predisposition to those cancer types. The core cancers are not only breast and ovarian, they also include pancreatic, prostate, and melanoma, and the inheritance pattern is autosomal dominant, which means there's a 50-50 chance of passing on a mutation if a person carries it to the next generation. The prevalence means how frequently do we see it in a population, and we see BRCA mutations about 1 in 300 to 1 in 500 individuals. And certain ethnic backgrounds, such as Ashkenazi Jewish individuals, are at higher risk to carry a BRCA mutation, and the prevalence among this group is 1 in 40. Red flags specifically for BRCA mutations are ovarian cancer at absolutely any age. So ovarian cancer, whether it's at 30, 40, 50, or even 80 years old, is a huge risk factor for carrying a BRCA mutation. And as Pamela mentioned, it's very hard to detect ovarian cancer. Often it's diagnosed at later ages. So if there are certain family features and suggestive of BRCA mutation, it's so important to catch it early. Breast cancer diagnosed under 50, as I previously mentioned, at 50 or under is a risk factor. 2 primary breast cancers. So, for example, if a woman gets diagnosed with breast cancer in the left breast and the right breast at the same time, that is very suspicious. Or getting a recurrence in the same breast is also suspicious. If the person was treated with a lumpectomy and not a mastectomy. Male breast cancer, as I mentioned already, is very rare. Triple negative breast cancer, which means estrogen receptor, progesterone receptor, and HER2 new negative. Those are more rare and aggressive breast cancers that have to be taken as a risk factor for HBOC, or hereditary breast and ovarian cancer syndrome. 2 or more BRCA-associated cancers. So, for example, if a woman has both breast and ovarian cancer, some studies have shown that her chance of carrying a BRCA mutation could be about 25%, so very high risk to carry BRCA mutations if you see those 2 cancers, or prostate cancer and male breast cancer, or recurrence of prostate cancer. Ashkenazi Jewish ancestry. So as I mentioned, the carrier rate for BRCA mutation is 1 in 40, and if an Ashkenazi Jewish female, for example, has a breast cancer at any age, she qualifies for testing. She meets criteria and needs to be managed differently. And that's as compared to somebody else in the population who might have, if somebody's non-Ashkenazi and has a breast cancer, let's say at age 80, they may not meet criteria for testing. So ethnic background is very important for us. A previously identified BRCA mutation in the family automatically makes somebody a candidate for genetic testing. Let's look at clinical features of hereditary breast and ovarian cancer. So as Angelina Jolie made so famous in the news several years ago by disclosing that she's a BRCA positive, we found out that her risk for getting breast cancer, as any woman's would be, is anywhere in the range of 46 to 87%. BRCA2 might have a tiny, slightly bit less of a risk, but certainly very high as well. Ovarian cancer risks, as you can see in this graph, in the very dark blue section here, the risk of ovarian cancer with BRCA1 especially is up to 63%. So extremely high risk, very important to detect if possible, as soon as possible to manage it appropriately. Pancreatic cancer risks are significant, especially with BRCA2, and prostate cancer risks for men are higher with BRCA2. So funny enough, BRCA1 you could see as being higher risk for women, and BRCA2 is higher risk for men. There are also that risk for melanoma and male breast cancer, and similar risks of breast cancer recurrence and other cancers recurring in the same individual. If the doctor doesn't know that they're a BRCA carrier, and the patient gets diagnosed with breast cancer, has a lumpectomy and radiation, they might go on to develop a second breast cancer if that mutation is not identified and if that woman doesn't receive appropriate care. So when we talk about appropriate care, we're talking about 3 routes of management for BRCA carriers. 1 is surveillance, 2 is prophylactic surgical options, and 3 is risk-reducing agents. Surveillance for women with a BRCA mutation include breast awareness and clinical breast exams starting at 25, and the frequency is every 6 to 12 months. So if a woman has, let's say, one person in the family with breast cancer over 50, she may not actually go for clinical breast exams more than once a year. But if she's found to be a BRCA carrier, she would have to go for clinical breast exams twice a year and would be thoroughly evaluating her own breasts. Additionally, she would be a candidate for breast MRI starting at age 25 and annually. So annually means every year, and she would be a candidate for both breast MRI and mammogram annually. And those could be at the same time or every 6 months, alternatingly. Ovarian cancer surveillance is not great. There's no very good screening test for ovarian cancer, but if somebody's a BRCA carrier, she's a candidate for starting transvaginal ultrasounds and CA-125 blood tests at age 30 to 35. Surgery is one of the best routes of breast cancer and ovarian cancer risk reduction. If a woman has a mastectomy, prophylactically, her chances of developing breast cancer are significantly reduced, over 90% reduced. A woman has an oophorectomy, and oophorectomies are recommended prophylactically when childbearing is complete or between the ages of 35 to 40. And the risk for ovarian cancer is reduced this way by as much as 96%. Unfortunately, we can never say 100%, but due to various reasons, including some residual risks for something called peritoneal cancer and just the lining of the gynecological tissues, but 96% risk reduction is significant. And also having the ovaries removed prophylactically reduces a woman's risk for developing breast cancer as well by as much as 68%. The third option for risk reduction are other risk-reducing agents. For example, oral contraceptives reduce the risk of ovarian cancer by as much as 60% in BRCA carriers. And so if a woman is deliberating whether to get an IUD or use some other contraceptive methods, oral contraceptives would be definitely indicated for her if she's a BRCA carrier. And very importantly, one of the most important things a woman could do who's a BRCA carrier is get an evaluation from a reproductive endocrinologist. So NCCN recommends that healthcare providers assess women and couples of reproductive age for these BRCA mutations and recommend a discussion of assisted reproductive technologies and a discussion regarding egg freezing or preserving their fertility and pre-implantation genetic diagnosis to find embryos that might carry the mutation and help the couple not pass on the mutation to their children. So this is a good time to note that this webinar series is goes together. Yes?
We're viewing the end of your presentation. I think there might be something that's a little wrong with your slides. I know that you're talking about, you were just on the reproductive options slide, but then it went straight to the knowledge is power and hope slide.
Oh, wow. Okay. Well, let me pause it and try to get it going again. How are we now?
Right now we're good. We're on the reproductive options.
Excellent. Thank you. Okay. So yes. So as I was saying, there's going to be another webinar on March 26th led by Dr. Matthew Letterman from Reproductive Medicine Associates of New York, and he will be sharing more information on this very important topic regarding fertility preservation for females and couples who have a mutation in the family. So definitely tune in for that. 6 to 7 p.m. on March 26th. Other options for women to reduce their risk of breast cancer are tamoxifen, which is a medication that's given often to women who to prevent breast cancer recurrence, but this medication has been shown to help decrease the risk in unaffected women as well. And there's other medications that should be discussed with the doctor as if appropriate for them based on their mutation status. Very quickly, I wanted to mention that there are medical management recommendations for men with mutations. Those would include breast surveillance, including self-breast exams starting at age 35 annually, and prostate cancer screening with prostate-specific antigens, PSA and a digital rectal exam starting at age 40, and those are to be done annually. As you might remember from the earlier slides, the risk of prostate cancer in men with a BRCA2 mutation is as high as 20%, which is at least twofold over general population risk. So both men and women have these medical management changes. I would like to quickly switch gears and talk about Lynch syndrome. Lynch syndrome is these 5 genes, and they are the most common causes of hereditary colon and endometrial cancer. The inheritance pattern is the same as BRCA1 and 2. They're autosomal dominant, which means either the man or woman could pass it on to the next generation. And while we don't have as famous a spokesperson for Lynch syndrome, the way we have Angelina Jolie for BRCA, it's important to know that Lynch syndrome is as common as BRCA, with a prevalence of about 1 in 300 to 1 in 500. So it's definitely very important to pay attention and learn the risk factors for Lynch syndrome and to properly manage your risk and the family's risk. So 5% of all colon cancers are due to Lynch syndrome, which is rather high, and the average age of colon cancer onset is actually 58. So when you think about, the multiple young or rare, the red flags, if you see colon cancer even after 50, that could be suspicious, depending on the pathology of the tumor and the rest of the history. Let's look at the right-hand side of the screen here in the green. Any individual with any of the following would meet criteria for testing. So if a man has a colon cancer under 50, that automatically qualifies, even though I just said that the average age of diagnosis is not until later. But what if you have 2 or more Lynch syndrome cancers? Lynch syndrome cancers are not only colon and endometrial, they're also ovarian. So Lynch syndrome is the second most common hereditary cause of ovarian cancer after BRCA1 and 2. And the other cancers associated with Lynch are gastric cancer, hepatobiliary cancer, and small bowel cancer, as well as pancreatic cancer and brain cancer, and an unusual skin condition called sebaceous adenomas. So if a person has 2 of these types of cancers, they automatically qualify. If a woman has endometrial cancer under 50, she would qualify for testing automatically and should be assessed. If a person does not have any of these cancers but has a family history, we would look to see if they have a 1st or 2nd degree relative with colon or endometrial before age 50, or 2 or more relatives with a Lynch syndrome cancer, one of them being before 50, or 3 or more relatives with a Lynch syndrome cancer at any age. So let's say a woman is 35 years old and her sister had endometrial cancer at 41, and then she has a maternal grandma that had colon cancer at 70, and maybe an aunt had colon cancer at age 75. Those are 3 cancers on the same side, and she would qualify for testing, even though many doctors might tell her that you don't need a colonoscopy until 50 because those are later onset colon cancers. Well, maybe she's somebody who needs more intense screening. So Lynch syndrome is a colon cancer syndrome that leads to an up to 82% risk for colon cancer in one's lifetime, and an up to 71% risk for endometrial cancer, as well as a very high risk for a second cancer in their lifetime. So of note, women who have only endometrial cancer or family history of endometrial cancer would present, they would have a mutation up to 50% of the time. So you don't have to wait to get colon cancer or to see colon cancer in the family history to assess somebody as being at risk for Lynch syndrome. Endometrial cancer is very common and could be present as the primary cancer in a female about 50% of the time. To manage Lynch syndrome, again, we're going to look at surveillance, surgery, or chemoprevention. The surveillance for Lynch syndrome includes starting colonoscopies as early as 20 to 25, or 2 to 5 years prior to the earliest diagnosis in the family. And if it's at times possible that somebody might have a very early onset colon cancer in the family. So for example, let's say if you're a 20-year-old patient and you have a brother that had colon cancer at 28, you might be a candidate to start colonoscopies as early as 18, or 10 years before the earliest diagnosis in the family. And you do those colonoscopies every 1 to 2 years. The location of the cancers or adenomas, which are polyps that form the cancer, are often on the right side of the colon in people with Lynch syndrome. So there are ways to tell based on the results and the location of the tumor whether it's more likely to be Lynch syndrome-associated colon cancer. Colonoscopies for some of the genes might start a little later, 25 to 30, depending on where the mutation is identified. The rationale for these frequent colonoscopies, typically, as everybody's aware, we recommend doing, societal guidelines recommend starting colonoscopies at age 50 and then doing them every 5 to 10 years. That's because polyps, which are the precursors of colon cancer, take about that long to develop in a person at average risk. But importantly, people with Lynch syndrome have a much quicker progression of that polyp to cancer, matter of 1 to 3 years, so very rapidly progressing polyps, and that is why we need to do colonoscopies much more frequently for these people. For Lynch syndrome, there are no prophylactic surgeries recommended to manage that colon cancer risk, but of course, every case has to be evaluated independently. You know, if there's a person that has other risk factors, like Crohn's disease or ulcerative colitis, they may need surgical interventions for those reasons, or for the combination of reasons. And but typically, prophylactic surgery is not recommended to manage colon cancer risk because it could be well managed with colonoscopies and surveillance. However, for women with Lynch syndrome, gynecological surgery is an option, specifically hysterectomy and bilateral salpingo-oophorectomy, which is prophylactic removal of the uterus and fallopian tubes as well as ovaries, and that is recommended when childbearing is complete. An option outside of a surveillance with colonoscopy and other tools, as well as surgery, is aspirin for prevention of colon cancer. There are some studies that show that aspirin could be a very good agent to help reduce colon cancer risk and should be discussed with your gastroenterologist. The Lynch syndrome gynecological management includes annual transvaginal ultrasound, endometrial biopsies every 1 to 2 years, CA-125 testing, and close evaluation for any changes in normal bleeding patterns that might require further evaluation, as well as annual pelvic exams. And those are all to begin between age 30 and 35. And again, as I had already mentioned, prophylactic surgery is recommended either when childbearing is complete or early to mid-40s. And we will definitely be taking questions at the end, so hold your questions. The management, so I had mentioned there's, besides colon and endometrial cancer, there are certainly other cancers that are at higher risk for people with Lynch syndrome. Those include gastric and small bowel cancer, and we would recommend adding an upper endoscopy to the colonoscopy at age 30 to 35, and those are to be repeated every 2 to 3 years. There's central nervous system cancers that are to be evaluated by neurological exam, 25 to 30, urothelial cancer risk, consider urinalysis, 25 to 30, and there are, of course, pancreatic cancer risks, and those are to be evaluated individually depending on the family history. So these are important management recommendations to highlight because oftentimes if people have a family history, if we think again about stratifying risk, if somebody has a family history of colon cancer, their doctor might be on top of it, and they might recommend starting a colonoscopy 10 years before that earliest diagnosis in the family. But think about it. If Lynch syndrome is not identified in that person, they might be missing out on all of these other physical systems that need management, such as upper endoscopy, or a woman would be missing on that gynecological evaluation, or some of these other important cancer risk prevention strategies. So that is where identifying whether a person is at hereditary or just familial risk becomes very important. The last bit of kind of genetics that I'd like to touch upon is this idea of multi-gene panel testing. So what we know now is that one type of cancer could be caused by many different genes, and one gene could cause many types of cancer. So our paradigm paradigm of genetic testing has really shifted from single gene testing to panel testing. And panel testing picks up twice as many mutations as single gene testing. And these other genes, which are really, many of them are well studied and are tested routinely now, are associated with breast cancer risks, ovarian cancer risks, and certainly other cancer risks. So this is, for example, a table that shows that besides BRCA1 and 2, there are other genes that are associated with significantly elevated breast cancer risks, and finding a mutation in these could certainly be associated with a change in medical management. Of note, especially of importance to women at risk for ovarian cancer, BRCA1 certainly is the biggest risk factor for ovarian cancer, as well as BRCA2. But as you can see here, STK11, RAP51D, the Lynch genes, which was talked about, MLH1 and MSH2, EpCAM, and a couple of these others are associated with ovarian cancer risks. And whereas we would recommend a prophylactic oophorectomy at about age 40, 35 to 40 for BRCA1 carriers, maybe that recommendation gets shifted closer to menopause for some of these other genes, but certainly there is an intervention that is medically indicated and supported by societal guidelines for some of these other ovarian cancer genes. So let's say you do a genetic test and you do a panel test as standard of care. There are three types of results you can get. One is a negative result. No, we did not find a mutation in these genes tested. That person would fall into that familial risk bucket, if you will, and maybe if there's other people that get tested in the family. The second type of result is a variant of uncertain significance, which means we found a change, but we don't know if it's harmful yet. So the lab has to study it further to be able to elucidate what it means and to give a definitive answer to that family. The third type of result is a positive result, and if we find a positive, we have to see what gene it's in, and then we'll manage accordingly for that gene. So if a person has a negative or a variant, medical management guidelines recommend for that person and that family to be treated as a negative and based on their family history. If there's a positive result in the orange, then we will manage based on the specific cancer risks associated with that gene. And if you have questions, you could certainly reach out to a genetic counselor or talk to your doctor about all these different types of results. So the benefits of genetic testing are often evident. They include individualized management for that person, accurate risk stratification, accurate risk assessment. In many cases, it alleviates uncertainty and anxiety for that individual and that family, finding out what is the cause of that cancer in me or my family. Limitations of genetic testing are genetic tests do not identify all causes of hereditary cancer. So we have thousands of genes in the body, and oftentimes we're looking at between 20 and 30 to 40, maybe 50 genes. So certainly the genetic testing is limited. One thing I would like to mention is that BRCA testing, because many people have questions regarding coverage. Is genetic testing going to be covered? All of this sounds swell, but will it be covered by my insurance? And what I would like to say is over 95% of the time, if you have a family history that's suggestive of a hereditary risk, you will be covered by your insurance, and BRCA testing is covered per the Affordable Care Act for patients without any cancer, but with appropriate risk factors. So with speaking for T.E.A.L with this webinar, I would like to highlight that ovarian cancer is such a strong risk factor for hereditary risk, for mutations, and anybody with a family history of ovarian cancer, whether it be in a parent or a grandparent, and at any age, will qualify for genetic testing. Genetic testing is available through healthcare providers, genetic counselors, or OBGYNs, or even internal medicine providers, surgeons, oncologists, and testing is run through a federally certified clinical lab with a turnaround time that's typically about 2 weeks, although sometimes it could be as long as 4 weeks depending on insurance pre-authorization processes, and that will be case dependent. So with that said, thank you so much, and I would like to turn the phone over to Pamela to ask any questions that might have come up throughout the webinar.
Great. Thank you, Flora. That was really informative. Thanks so much for doing that. You can hear me now, right?
Yes.
Great. So we've got a lot of questions coming in. I'm going to start with where can we find a genetic counselor, and is it expensive? That's a common question that we do get too.
Yes.
So.
Yes. And you know, I thought of this as I was presenting. I should have included a slide with resources, but that's something that we could definitely update or find. Even I think we have it on our T.E.A.L website. So one good resource is nsgc.org. So that's the National Society of Genetic Counselors page, and they have, depending on where you are located in the United States, a list of resources. By resources, I mean list of clinics and genetic counselors with their email addresses and phone numbers to their clinics to be able to make an appointment. And also, another way is if you don't want to see a genetic counselor, you could ask your doctor if they work with any in their institution and if they could get a referral. And genetic counseling is typically a covered service. It's going to be really case dependent, depending on the insurance company, whether there's some kind of special plan that covers the actual counseling process. But I could say that typically in institutions, it's a covered service.
Great. And I just want to take a minute to remind anybody, if anybody else has questions, don't forget you can ask them up at the chat bubble, and Melissa will be receiving them. So Melissa, I do have a few more questions in front of me, but if there's any more, do jump in and let us know. The next question is, who decides which panel is best for me, a genetic counselor or the doctor?
Great question. So the beauty of panels now is that they cover multiple genes that are associated with common cancer types. So oftentimes, these days anyway, a panel will include a risk assessment for both BRCA genes and the Lynch genes, and maybe a couple of others. I work with Myriad Genetics, and we offer a test called MyRisk, and that's a 28-gene panel, and the genes on the panel are associated with, concrete risk for cancer, and they've been very well vetted to be associated with cancer, and the choice. So there's other panels out there. Some have more genes, and it's important to really make sure you're going to a source, whether it's a genetic counselor or a physician, that is very careful about ordering a panel from a lab that is a good lab. So that means that they have accurate results, because the one thing I didn't mention in my presentation toward the end of it is that there's no FDA oversight over genetic testing. So in theory, there's a lot of different labs with many different genes that are being tested with different levels of accuracy. So definitely ask your doctor when you're undergoing the test, what lab are you using, and is this a good lab for me to use for my genetic test? Will it be accurate?
Great. Okay. What would you say about the recommended age for genetic testing, and why is there an age requirement? So I've heard different things as well. We've heard that there's, and we even advocated on our website, that usually over the age of 25 is suggested. So why is there a reason for that? Someone's asking.
Wonderful. So that is a really important question. That's a question that comes up a lot, right? If you test a woman and she says, does my daughter need testing? She's 12 or 14 or 8. Well, the answer is these are autosomal dominant adult onset conditions, so they present usually later in life. So what that means is when something's not a childhood onset disease, we don't need to test that person until they turn 18. Some schools of thought do recommend not testing until 25, because that's the age when screening usually begins. So for example, if you're a BRCA carrier, you're not going to start breast MRI or mammogram before age 25. But you might start clinical breast exams at 18. So between 18 and 25, erring closer to 18 would be a good option. If somebody's 18 and getting tested, they may not start intensive surveillance until a little bit later, but maybe they're going to meet with their doctor and make a plan. Maybe they might meet with a reproductive specialist and talk about fertility preservation, making plans for when they might have kids. Just start life planning a little bit sooner. Same thing for Lynch syndrome and some of these other genes. So perhaps that's something we'll hear more about from Dr. Letterman, who's presenting on March 26th.
Flora, I have one question that came in. it says, is genetic testing ever inaccurate? Are there such things as false positives when it comes to genetic testing?
Great question. And that ties into what I was saying a little bit earlier regarding FDA oversight and lack thereof. So the answer is yes, a false positive is possible. That is why it's extremely important to go with a lab that has a lot of experience in the test. So, for example, Myriad has been a lab that's been around since 1990s. They've been doing hereditary cancer testing for over 20 years. There's a lot of science, a lot of research, a lot of genetic counselors that meet regularly to make sure that the right equipment is used, the right technology is used, and the accurate result is provided. But there are many labs that have recently started out. So they've been doing this maybe just a year or two, maybe 3, and their methodologies are not as well vetted. So it is important to definitely try to go with the most accurate lab possible, and what a person could do is talk to their doctor and make sure that they get a good kind of action plan, or when they talk to their genetic counselor, to make sure they ask, what lab are you using for my test? Is it the most accurate lab? You know, do you know of any cases of inaccurate results from this lab?
Great. Okay. I think we have time for one more question. So how often should someone get genetic testing? Somebody wrote in that they've already had genetic testing done, but it's been many years ago. Should they consider doing that again, and how often should that happen?
Yes. So there was a bit of a revolution in genetic testing that occurred between the years 2013 to 2014, and that revolution was we went from single gene testing to panel testing. So in the past, if you had a family history of, let's say, breast and ovarian cancer, you would have only had the BRCA1 and 2 gene done, and maybe not even in its entirety. But starting with 2013, roughly, plus or minus a year, there was panel testing. So people started getting, instead of 2 genes, multiple genes done. So, the scope of the test expanded. And what that means is if you were tested over, let's say, 4 or 5 years ago, you should definitely talk to your doctor or genetic counselor about, is there any more genetic testing that could be right for me? Because perhaps that person did not have as many genes as they could get analyzed, and not as thorough of a risk assessment. And one last thing on that is genetic space is constantly evolving. So what that means is even if you've had the most up-to-date panel 2 years ago, maybe 2 years from now, you want to circle back to your genetic counselor or doctor and ask, is there anything more out there? Because every year I see more and more genes being tested, more and more interesting, maybe not single gene tests, but other types of genetic analyses that are being available.
Great. Well, that was really informative. I think we got a lot of people's questions in, so thank you. Thanks for joining us. I wanted to take a few more minutes to just tell everybody a little bit more about some other things that we have coming up on part of this genetic and family planning series that we have. So there's a fertility and family planning considerations for those with genetic and ovarian cancer risk webinar coming up with Dr. Letterman, which Flora mentioned a little bit earlier. That's on March 26th. So if you're interested, it is part of the series, and just RSVP the same way you did for this one. And that's going to really be pretty informative and interesting. And anything that you may not have had answered at this webinar or the next one, feel free to use our website or contact our office if there's anything else that you're interested in learning more about. We do have other workshops coming up that we just wanted to tell everyone about. We often do genetic workshops, so this isn't the only one. We usually do them a couple of times a year, so if anyone has other genetic interest, please let us know. So I do want to thank Flora and wrap up with just letting you guys know that we have some really exciting events coming up. There's our 10-year anniversary gala at the Brooklyn Museum. Tickets are on sale right now, and it's just next month. It's coming up really quick. We also established Ovarian Cancer Awareness Night at Citi Field, and that takes place every year now for the last 7 years. It's during the Subway Series this year on June 8th, and tickets are available right now. And also we opened up registration for our Brooklyn T.E.A.L walk. But for those of you who may not live in New York City, we also have walks that take place in other cities across the country, and we also have virtual walking opportunities. So you don't even need to participate in the event, but you can support the event and walk for a loved one that you might be interested in supporting. So. And lastly, there's just many different ways to get involved. You might not, again, live in Brooklyn or are able to come to our community center. And there might be other ways that you wanted to get involved. We have a lot of ways to even shop. Who uses Amazon? Pretty much everybody. We have an Amazon Smile shop that part of the proceeds go to us, and it doesn't cost you a penny. It's just part of the way you check out, and you choose Tell Every Amazing Lady. And there's also some tribute plaques and ways that you can dedicate things to loved ones in our community center. If you had any questions or wanted to get involved, just let us know. And then when we're done with all of our webinars, we like to send out a quick little survey to just see how it went. Tonight was a very snowy, stormy night with some Wi-Fi connection issues, but we made it through, so thank you for hanging in there with us. And if you have any other comments or suggestions on how we can continue to make these workshops better, please fill out that survey. You're going to receive that by email at the end. So thank you for your time, and stay safe in this snowstorm. Enjoy the evening. Thank you, Flora.
Thank you.
Okay, good night, everybody.